Welcome back. Following the opioid crisis, the Food and Drug Administration approved an over-the-counter version of the opioid overdose treatment drug, naloxone. Joining me to discuss this effort is Franklin Taveras, Juan Cortez, and Dr. Alex Bennett of NYU's School of Global Public Health Opioid Overdose Prevention Program. I want to thank you all so much for joining me.
Thanks for having us. Thank you.
Now, Doctor, can you just talk about, naloxone and Narcan and what that is?
Sure. So naloxone is a very safe and effective overdose reversal medication. Basically what happens with an overdose is someone takes too much of an opioid and their breathing slows down and the breathing eventually stops. So naloxone, essentially what it does is you can give someone naloxone intranasally, pull the back, right at the nose, and essentially displaces the opioid receptors in the brain. The person comes back to life, starts breathing again. It's a very safe medication. It's been around, used by paramedics since the 1970s.
It takes about 2 minutes to take effect. Once you administer it, the person comes out of it. We usually tell people that you should tell them they had an overdose because what happens is they're at point A and now they're at point C. They lost B. So we always tell people, tell them you had an overdose, we gave you naloxone. Naloxone works for 90 minutes. It blocks the receptors. You can't get any more opioids in your system. They won't work. So we like to tell people to stay with them for 3 hours. If you have to leave, we tell them the rescue position. Or if you call 911 and they don't arrive and you've done the rescue position, we also recommend rescue breathing. Rescue breathing is not part of CPR. Okay. CPR is chest compressions. Rescue breathing involves putting the person on their back and giving mouth to mouth. So
naloxone has actually been around, just to add a little bit to that too. It's been around in an injectable formulation really since the 1970s, used effectively by paramedics. So as the overdose epidemic started to get worse and worse, especially in the late 90s and early 2000s, more and more people were dying. So community groups actually started giving naloxone out directly to people, right? To people who use drugs especially. So again, this is a very safe, effective medication that people were able to use to save each other. The nasal naloxone actually was really approved by the FDA not until about 2015. And so this is really what primarily we about now, is the intranasal formulation.
Now, Juan, can you talk about, how naloxone was distributed prior to, it being available over the counter?
Well, initially, only paramedics had access to naloxone, and they would give like a really high dose, which would put people into immediate withdrawal, which was, it saved people's lives, but it put people in a bad space. Eventually, activists fought for the right to it be distributed to community members. So it was able to be distributed by doctors or physician's assistants. Then it evolved to the point where it was able to be distributed by outreach workers. And the saturation program took into effect where it's just distributed to all members of the community to save lives.
Now, can you also expand a little bit? I know you are also part of an organization, On Point NYC.
Correct.
Can you just expand a little bit about the work that you do to help others in regard to this?
So I believe that the distribution of naloxone is very important in saving lives. But I also believe it shouldn't be just about handing out kits. It should be about getting people connected to services. Like one of the things that we do at On Point is that we have a one-stop shopping where people could come in and receive services like mental health services. I specialize in holistic health, so I get people connected to acupuncture, to massage therapy, to Reiki. We have medical providers, we have showers, we have washing machines, and we have the first overdose prevention center in the country where people could be monitored for overdoses and be brought back. And I think that to put it all in a nutshell, is yes, getting the naloxone is out there, but people also need the love and the resources that have been affected by this opiate crisis. It's much more than just handing out a kit.
Right. I'm so glad that you mentioned that, because I think sometimes when we talk about these things, it's very like A, B, C, but there are, like you mentioned, there's a lot of things that happen in between. So I'm really glad that you mentioned that. Doctor, can you just talk about, according to the Center for Disease Control and Prevention, the leading cause of accidental deaths in the U.S., with 80,000 of those deaths involving opioids. Can you just talk about why, this is just such a high rate of, so many people dying from this?
Yeah, I mean, the overdose rate's been going up and up and up, almost for consistently for about 20 years. In the last 2 years, it's been setting records in the number of people who have died. It's really a national, critical public health crisis. Really in the late 90s, you're seeing increasingly overdoses from prescription opioids. And then by the early 2000s, it was much more heroin, high purity heroin. What we've seen since about 2013 is more and more fentanyl, a synthetic opioid in the drug supply. Fentanyl is roughly 80 to 100 times more potent than heroin. And it's really in everywhere now. It's in a lot of the heroin, the majority of the heroin, counterfeit pills and things like that. So people don't really know what they're getting. We have an unregulated drug supply, okay? So people, it's not like going to the pharmacy and knowing you get a 5 milligram Percocet, right? You have no idea. It's Russian roulette, rolling the dice, right? So you have no idea what you're getting. So more and more people are, using potentially the same amount, and now it's a much higher dose. It's very lethal. So people are dropping like flies. Really, I would say it's the fentanyl that's going on that's really increasing. And then, and as Juan was saying in Franklin, with COVID and, really thinking about the historical impacts of structural inequality and racism and things like that, right? There's a lot of people who are sort of very disadvantaged, right? There's a lack of penetration of a lot of services in a lot of communities of color, right? There's mental health challenges, there's underemployment, right? All of these things on top of a very bad drug supply, right? So these things is like this perfect storm for overdose morbidity, mortality.
And there's a lot of stigma around drug use.
Huge stigma.
People who use substances, especially opioids, they're seen as morally defective. Something's wrong with them. Why can't they just stop? That's not our goal. Is not why can't they just stop, but keeping people alive so that maybe they have the opportunity to change their mind, change their behavior, and stop or improve their behavior. Be better at doing the things that they're doing in a healthier way, lessen the risk. We also have the FTS program, the fentanyl test strip program, which is part of DOH's initiative for fentanyl. Since they recognize it to be such a dangerous substance, they are allowing outreach workers to give out fentanyl test strips in the hopes that people will test their supply before they use. People are not going to not use, but at least they'll go slow.
Right.
They'll call someone and tell them, hey, I'm not sure about this. They'll do an overdose prevention plan, which is what we always push people to do, which is sometimes use in public, which sounds terrible. But you know what? If you use alone, there's no one there to help you.
Right. Now, Juan, can you just talk a little bit about, he mentioned the stigma. What can be done to reduce the stigma surrounding drug overdose?
Well, I think one of the main reasons that there's such a stigma is that people that identify as people that use drugs are seen as criminals. And that in itself is a stigma, right? Also, the fact that we have to acknowledge that not everyone that is at risk for overdose has a certain look or a certain social status or even like employment status, right? Overdose doesn't have a face. Anyone could die from an overdose, and that's the message that we got to get through. And once we acknowledge that this is not a criminal problem, but it's a health issue, and that these are human beings that are not categorized or shouldn't be categorized as the drug user, but as artists, musicians, family members,
Fathers.
Loved ones, human beings. And I think that once we can get past that label, then we can make progress and reducing the death rate of overdose.
Now, Doctor, I want to know, now that this is more available, can you just talk about the responsibilities others may have to save lives? I know that recently, like in restaurants, they're making it available. What responsibility does an everyday person have in regard to just this crisis that we're experiencing?
Okay, so I guess a few things. One is that now that naloxone, and again, just the nasal formulation is over the counter. The intramuscular is not over the counter yet, right? And it's a much cheaper formulation than the intramuscular, right? So that's something to keep in mind. Not everyone can afford the intranasal. Our program gives it out for free, and that's what we really need to do is we need to keep these low threshold, free, no cost, low cost naloxone programs going. We need them out there. I think what's happening is that with the over the counter, we're going a long way towards helping to normalize naloxone as a medication that we should have in every medicine cabinet, backpack, park, everywhere. Okay, it's just normalize it, make it very normal, and that helps to sort of saturate communities, right? So it should be everywhere. It should be everywhere. When someone is having an overdose, it should be available with a bystander.
I know that you mentioned that you said that there were two. Can you just explain which one is going to be over the counter?
Yeah,
and
which one is when we started. So basically what's happened is, again, the injectable formulation, which started in the 1970s, was being used and distributed by community groups throughout the 2000s. Much cheaper, right? Remedy Alliance for the People is giving it out for about $2, $3. New York City Department of Health has an incredibly good infrastructure, and they are really great public health. They give out naloxone for free. Over-the-counter injectable did not get over-the-counter status. Okay, the nasal did, and that I think has to do a little bit with the stigma associated with injecting and people who inject drugs. Right, again, reinforcing that stigma. Right, so again, people can still access the intramuscular, but over-the-counter will be intranasal. Intranasal, again, it's just very simple, right up the nose. But we don't quite know all the costs and things like that, but roughly $70. And so that can be a barrier, right? That can be a barrier. And we don't want people sort of doing a cost-benefit analysis. Should I get it? Should I not? We want them just to have it all the time for free.
And we created the Department of Health created the NCAP program, which was the Naloxone Co-Payment Assistance Program. This was done back in 2016, I think. And it was to collect all the pharmacies in New York State and let them be part of that program, so that they were not just giving out naloxone, but also educated, or the pharmacists were educating people also that were getting it. That program still exists. I'm not sure in what form, because now that it's over the counter, it might change because it was part of the insurance. But it's hard for someone who doesn't have skin in the game, kind of, to say, I'm going to spend $50 for something that I might never use.
Right.
So the idea is to keep the free naloxone, to keep us working, keep us going out into the community. But then there's that individual who may be like a grandfather or a grandmother and says, you know what, my nephew is having problems with opioids. Let me buy this. Goes to the pharmacy and gets it, because they don't have the resources and they don't know about the syringe exchange programs. They don't know about On Point, but they do know about the pharmacy. So
can you just talk a little bit more, expand on like just the resources?
The resources?
Yeah, just resources available.
So when we engage people in the street, we have conversations with people, right? We initially talk to them about the risk factors of overdose, getting them trained in the kit, handling the kit, but also talking about what their needs. And that usually comes out like naturally for people. It's like, yeah, I'm glad I have this kit, but I'm hungry now. So the outreach workers, we're all equipped with the resource guide, and we directly either we escort people to the location or we guide people to the locations. Different harm reduction agencies, whether it's they're trying to manage their drug use or they just want something to eat, they want to access some type of support groups. And it's just about talking to people and getting them connected to those services. And like I said, and if we are in that position where we have to escort someone and take them there and introduce them to people, then that's what we do.
All right. Well, I want to thank you all so much for taking the time to talk to us about this.
Thank you for having us.
We've come to the end of our show today. I'd like to thank all of our guests for joining us and you, the viewers, for tuning in. If you missed any part of today's show, you can catch the Recable Cast at 5 and 10 p.m. on Optimum Channel 67 and Verizon Fios Channel 33, or watch anytime on the web at bronxnet.org. I'm Kibin Alleyne, wishing you and yours safety and wellness now and always. See you next time.